Good afternoon, respected judges and dear colleagues. So, negative dysphotopsia, an enigma of the past. Negative dysphotopsia is a burning question. It is ubiquitous with uncomplicated in-the-bag phacoemulsification with any type of lens that we use. In the immediate postoperative period, the incidence is as high as 12 to 45% and even more is reported in the literature. It comes down thereafter. So, given the burden of a cataract surgery is done in India, should I go on?
Please start again when the timer starts.
Okay, should I go back? Okay.
Please start the timer.
Just start the timer and
Yes,
you
yes,
also start
it has been
presenting.
started.
So can you just go
From
back
the
to
beginning,
slide?
yeah. From the beginning.
I cannot go back here.
Okay, okay, you start from this point.
Yeah.
So with the burden of number of surgeries that is done in India per year, about 15% of what the phaco is done, so about 8.34 lakhs of patients suffer from negative dysphotopsia in the immediate postoperative period, though it comes down to 2.2% after a lot of time. Excuse me, the slide is not moving. Can I have the slide from the beginning?
Please come and help. Can you please come and help?
Can I have from the it's now
Slide is not moving.
Management of strategies have come into place. So there are IAC cap, piggyback IOLs, laser truncation of the IOL, whatever, there are lots many. But the most popular are reverse optic capture, primary or secondary, and back to sulcus IOL exchange. So aim of the study is to find the incidence of negative dysphotopsia if we place the IOL in a particular manner. Let's see how. In case of sulcus placement, the effective lens position and centration are at stake. They're not very well defined. If you do a reverse optic capture, there is iris chaffing, release of pigments, and the sequelae. So, to have the best of both worlds, I place the haptics in the sulcus, and the optic is captured inside the rhexis margin, inside the back. So, it's a descriptive, observational, non-randomized, consecutive retrospective study done between April to December 2023, where a particular band of hydrophobic acrylic multipiece lens is placed in the sulcus, and the optic was aptly captured inside the bag of 5.5 millimeter rhexis. A double masking is done whereby a telecaller would call up the patient on the second postoperative day before the patient reports for first follow-up to the doctor. So there is no bias, and the telecaller inquires about the black shadow and notes it down. So here suggests the way how it is done. A multipiece lens is first haptic goes into the sulcus in front of the optic, in front of the rhexis. The second haptic also goes into the sulcus. Thereafter, the optic is nudged so that the optic edges are below the rhexis margin. So you nudge, so the square edge of the optic does not cause iris chaffing. In the immediate postoperative period, you can see the haptic is out of the bag in the sulcus, and the optic is covered by the rhexis. This is how it looks. So the results, 223 patients were taken up, of which the negative dysphotopsia was noted in the immediate postoperative period as 3.5% vis-a-vis 15 to 45% in the immediate postoperative period as reported in the literature. So what does this study add? The reduction of negative dysphotopsia through strategic placement of IOL is possible. Furthermore, innovations in various types of IOL design and surgical practice can be done based on this. So we have ignored it for a long time, saying that it will go away on its own. Wait for some time. But with this premium IOLs coming into play, when somebody walks in the first post-operative visit and says that I'm having this negative dysphotopsia, black shadow, do something for me, why is it there? So we must give it a thought. It is time for us to give it a thought for all types of IOL. So this may predict us to design the IOL optics and haptics in a new way, whereby we can place the haptics in the sulcus and bring the plane of the optic a little bit in front.
They were all square haptic ones. Three piece.
All three-piece lenses, because I could have done it with single-piece lenses, but that would have raised eyebrows. But first, let us do it safely.
And the capsular axis was optimized. They were all comparable.
Yes, all I marked it on the somewhere done on this thing, and I marked it with a marker on the cornea. 7.2 millimeters on the cornea will give me 5 millimeters on the
Okay.
rexis. So it
So
was
what was the incidence of PCO in these cases? Because
PCO.
you see,
It is a follow up is about 6 months. Highest follow up. There's
Yeah.
not much of PCO, but PCO can happen. But
because this is lying little up anterior, what
agreed.
should be there
Sir,
on the
sir, the purpose of
so it
this
should
study,
not providing barrier to the PCO formation.
I understand, but the purpose of this study is negative dysphotopsia is
Yeah.
the main point. I understand it is if we are taking it off the PC, the incidence of PC
And
might be
how
more.
common you find the NDs negative dysphotopsia is common? How common is it
In which in normal
in
lenses,
normal cases? Yes.
very pretty high, and the literature puts it at 15 to 67%.
Yeah.
Depending on, and one more thing, where you solicit the question, you ask the patient, are you seeing the black shadow? Some more patients will say, yes, I'm seeing it. But whatever this 3.5% I have shown, we solicited the, we of our own, we put up a leading question that, are you seeing this black shadow? After that, it has come 3.5%. So
Right.
that's how it is. But if you don't ask, it will be even less.
So there are many ways to deal with these things. One is as you shown it. Yeah, there are other methods also to deal this condition.
Piggyback lenses, truncation,
Even
capsulotomy.
capsulotomy helps a
you
lot,
can bring it
yeah.
out of the bag, reverse optic capture.
Yeah.
But the reverse optic capture below the
Okay.
iris moves and the pigments are released.
Right.
So they can be done as a scapegoat situation, but should not better be avoided.
And these the haptic orientation, how are they oriented? The haptics.
The study which was done with inferotemporal position of the single piece IOL's haptic study, but this being a multiple study, it is irrespective of as because it's a very thin haptics, so the position of the haptics is
doesn't have
any bearing on the negative dysphotopsia and the positioning of the IOL. And one more thing, as because it is captured by the rexis, the plane is defined. If you place it in the sulcus, it is somewhat undefined and the centration may be at stake. But if it is captured snugly by the rexis, the plane is defined and also the centration is also profoundly defined.
I think negative dysphotopsia is more common in surgery, which was done perfectly well centered, very clean,
Absolutely.
This thing. And most of the patient over the time, they just ignore it. The reason being, one is they ignore it. Second is the fibrosis which occurs on the capsular margin. That also take care of this
It
thing.
is in the immediate post-operative period. It's a lingering question. That is what we are bothered about.
Right. Thank you.
Thank you so much.